already, and we're just at 12:30 now. So I think we're going to get started. Really pleased to welcome all of you to the second webinar in our Spring Public and Patient Engagement Collaborative webinar series. I'm just going to remind people, if they could, just to make sure that they mute themselves. I understand some of you may not want to have your cameras on. That's completely fine. We're happy to see you if you'd like to turn them on at any point, but I will ask if you can keep yourself muted while we're giving the formal part of the presentation. We are going to build in some time for Q&A, and of course the chat is open for you to contribute to throughout, and we have members of our team who will be responding to questions in the chat as they come up, so please feel free to use that. And also to interact. So we are recording this session. I think you'll be prompted to about that as you join. I'm really pleased to, on behalf of the Public and Patient Engagement Collaborative, to be leading this webinar, but co-presenting with my colleague for a very long time, Carolyn Canfield from University of British Columbia and from the lovely city of Vancouver. So we will be co-presenting on behalf of our Canadian Patient Partner Study team. What I'd like to do first is to acknowledge the traditional territories that we're gathering on. So in my case, I'm at my office at McMaster on the McMaster University campus, which is located on the traditional territories of the Mississauga and Haudenosaunee Nations, within the lands protected by the Dish with One Spoon Wampum Agreement. Carolyn, do you want to let us know where you're from?
Thank you, Julia. Yes, I'm joining you from the edge of the campus of the University of British Columbia on Point Grey in Vancouver, which is on the unceded ancestral and traditional lands of the Musqueam, Squamish, and Tsleil-Waututh nations. And thank you, Julia. It's great to join you, and it's great to join everyone in the audience. Thanks.
Okay, and please feel free to let us know where you're joining from as part of our land acknowledgement. And just to conclude by just really honoring all First Nations, Inuit, and Métis people, their valuable past and present contributions to this land, and really important to acknowledge those who were here before us and recognize our responsibility to respect and honor the intimate relationship that Indigenous peoples have to this land. So wanted to start our presentation with a slide that shows our wonderful team members. So Carol and I are the two kind of formal representatives of the team presenting to you today, but we, as you can see, have a really wonderful group that we have been collaborating with over the last number of years, that I would describe as interdisciplinary, in that we bring a multitude of different training, experiences, areas of focus that we bring to the field of public and patient engagement. Also a combination of more academic and more applied expertise in this area. We're pan-Canadian. We don't cover all of the provinces and territories, but actually we do a pretty darn good job. I went through it again in my kind of reflections before the presentation, and we cover a lot of ground across this country. And I think most importantly, it is a fun, really collegial, but tough group in a good way, really critical in a very constructive way. And we've had some fabulous discussions. So in my view, really one of the most valuable research collaborations I've had, and quite a unique one, as I think you're going to learn throughout the course of this presentation. Carolyn, do you want to say a few words about yourself?
Sure, I'd be happy to. So I'm a patient partner. I've been involved in this kind of work for 15 years. And in the Canadian Patient Partner Survey study, I and Marianne Levasseur joined as co-partners on behalf of the Patient Advisors Network, which is an independent network of patient partners from across Canada that was established in 2017. And I met Julia before that time, but it was certainly in my mind to consider how to link up with people who were doing this kind of work, because we knew it was isolated and often lonely work, and having mentors and colleagues and people to reflect with was very important. So Julia and I talked about the importance of finding out who we were. I don't know, Julia, it must have been like 8 years ago, 9 years ago, maybe longer, as the patient partner movement began to really roll, for a variety of reasons that we can get into later. But it was that curiosity that we discussed many years ago that achieved fruition in this study.
Great, thanks, Carolyn. And in my case, I bring a social sciences and health policy background to this study, and really to, my longstanding interests in what I would describe as the role of publics. I kind of use the plural term publics, because publics, of course, can include citizens, service users, taxpayers, citizens, a whole group of different people who come into this really interesting, messy field, and have had a longstanding interest in understanding who these publics are, how do they want to contribute, how do they contribute, and how do we understand how this all works and how we can do better in this field. So we are going to give you a brief overview. I know some of you may have quite a bit of understanding of the Canadian Patient Partner Study. You may have even actually participated in the survey that we're going to be presenting to you today, or even in the next phase of our work, which are the interviews. So some of you may have a good amount of background information, but others may be very new to this study. So we wanted to start by giving a very brief overview. So our research aim, and so this is when, as Carolyn spoke, when we started to think about what do we really want to do with this study, and as we were developing the research proposal to submit to Canadian Institutes of Health Research, or CIHR, we really wanted to gain very, very simply, but not so easy to do, gain an in-depth understanding of the patient partner and advisor role and we described it as this emerging resource, and I guess not so emerging now, kind of quite a bit further along in its developmental stages. But really, when we were first thinking about this study, it was, I think, earlier on, maybe more even, in cases of people like Carolyn, very, very kind of pioneering efforts in this field, but starting to think of it as really an emerging resource to the Canadian health system, doing a lot of heavy lifting in a variety of roles, and important to think about, who are the individuals who are playing these roles, what is the role itself, and what are the experiences with it. So our objectives then were to really describe, who patient partners and advisors are across the country, and to do that more in-depth examination, and all with the mindset of, we need to understand it better so we can sort out, how do we improve? What are the challenges? How do we move forward in supporting this role? And so our study actually is comprised of 4 phases. Really, we're at kind of moving through into the 3rd phase now, but always that phase 4 piece, the research analysis, really embedded throughout. So we carried out a systematic review of the literature, which has now been published. We've actually completed the survey, which has also been published, but we're generating new outputs because it's such a rich set of data. And we're now into the interview phase of our work. And just to give you a sense, and I think this is, really, really interesting, and probably one of the most innovative aspects of this study is its design, right, for the phase 2 survey piece in particular. So we're looking around to see whether there were existing studies or surveys of patient partners internationally or even in Canada, and there are very few. There are some, but really a small number, and they tend to be fairly localized to organizations, to particular communities, populations. So not really the kind of the breadth of coverage that we were looking for in our work. And so we had to kind of start from scratch, from the drawing board to kind of come up with our own design for this. And we also were struggling with this whole idea of, well, how do we even define a patient partner? Because in fact, one of our questions in the study is how do people actually identify themselves in their roles? So we arrived at the design of an online cross-sectional survey, meaning one point in time of what we describe as self-identified patient partners. Now, we did give some kind of sort of eligibility criteria when people kind of were approached or thinking about whether they would want to complete the survey. We said that we're looking for people who are drawing on either past or current experiences with the health system to try to improve it in some way, usually through the involvement in activities, right, of a particular group, organization, or government. So we gave this kind of broad set of eligibility criteria to people to think about, but then people identified themselves as patient partners from that point on. Our structure and content was informed, as I said, from whatever we could find out there in the literature, and knowledge among our team members about surveys that existed even within some organizations. And of course, we contributed a lot ourselves as team members through our mix of academic researchers, patient partners, and engagement practitioners. As Carolyn said, this was very much co-designed, a survey co-designed with members of the Patient Advisors Network. So Carolyn and Marianne were the two kind of representatives who were on our team, but in fact, we reached out much more extensively within the Patient Advisors Network, as well as in other organizations to ensure that we have a lot of input from patient partners themselves in the design of the survey. Carolyn, were you looking to jump in?
Yeah, I'd love to just jump in and describe what that process of co-design looked like. Marianne and I were co-leads from PAN, and when we began to create the structure and then the actual specific questions in the survey, we worked with a team of people who are associated with the Patient Advisors Network who were really keen to get involved in this. And I guess there were three perspectives that we took. First, what were we curious about? What did we want to know about the patient partner population across the country? The next is, what questions did we want to be asked? What were what was the new knowledge that we wanted to have discovered and well known? And I guess the third was, what did we think was going to contribute to the support of partnerships with patient and community members looking ahead, looking forward?
Thanks, Carolyn. And just a couple of other important points. We've learned this from previous work with patient partners that we really needed to make sure we had a mix of closed and open-ended questions. So closed meaning kind of scales, very, yes, no, or scaled questions that would be easy to analyze because you're pulling a lot of information into a single question, but also wanting to have opportunities for the respondents to provide their comments. So more open-ended questions or open kind of text box, right? Opportunities that may accompany a closed-ended question. And of course, we were very mindful of keeping this to a grade 9 reading level, including minimal jargon. And also importantly, the survey was designed and administered in English and French. Carolyn, again?
Yeah, we were very well aware as we began to explore the language used is that patient partners have oftentimes a different definition and a different use of language around this kind of activity. So part of our work was ensuring that the questions were going to be understood in a way that we thought patient partners could most easily understand. And the importance of the open-ended questions was essential because we knew that many questions would cause the survey respondents to consider other aspects that might be embedded in the questions but weren't in our options. And so having that open-ended free text contribution has turned out to be incredibly valuable, as I think you'll see.
Yeah, so just before we move to that and start to get into the results, we thought it was important to share with you, and this was very much part of the original, planning for the research study. So in our proposal, we actually talked about 5 analytical domains, right? These are kind of what do we really want to explore in this study overall, but in particular within the survey. And so we looked, at these 5 domains. So demographically, who are Canada's patient partners? How do we describe them in terms of their their characteristics functionally, right? How do they come into their roles? What activities they involved in, with what time commitments? How long are they in these roles? Philosophically, of course, we want to understand what motivates them to do what they do. Professionally, right? Thinking of this role as in some regards as a professional one. So what are those skills that they bring already, that they need, that they would like to build on, and related to building expertise in their roles? And what are the perceived impacts of their partnering work? And then really importantly, an ethical lens, right, that we wanted to bring to this study, which focused on the challenges and or stressors, right, that patient partners face and experience in their roles. And so in terms of just some brief details about the implementation of the survey was completed between October and December 2020. So all of you will remember what was going on at that time. So a challenging time, one that I think was maybe a hard time for some people to contribute to the survey, but also maybe a time when many people had more time for this kind of activity. So I think it splits in different ways in relation to the pandemic. And so our respondents were recruited mostly through patient partner networks, obviously MIPAN being one of them, but others as well, and through us really flooding networks of ours, health system organizations of a variety of types, through direct email, through social media, using Twitter primarily. Of course, as you can imagine, there is actually no database of patient partners across the country. There are maybe smaller, sort of more localized understandings of patient partner networks within some provinces, but certainly not in many others. So we were really starting from scratch here in terms of even building up the sample, right, that we were looking to survey. So really pleased with the ability to obtain 603 survey responses. So these were, over 600 completed surveys, which is pretty incredible, given that we're a relatively small team and kind of pushing this out almost through word of mouth, so to speak. Really interesting when you look at time to completion, to take a median time of 37 minutes. That is a very long time to spend on a survey, which I think shows the level of interest and commitment, and really, frankly, the desire to be heard, right, through this survey. And really incredibly over 500 pages of open text data. So these are these open text boxes, the comments. So of course, we're really pleased that we provided that opportunity. And I think we were clearly right that you needed to provide this opportunity, because the respondents wanted to tell us some things that couldn't be captured in those traditional closed-ended responses. So an incredibly rich data set that I think will be yielding all kinds of good things for some time to come. And we're only just starting into that process. This is the paper that we're focusing our presentation today on. This has been published now in BMJ Open. And so, apologies for that. So we are basically organizing our remarks around this paper. We are, sorry, I'm just losing my little move ahead. There we go. Arrow key. So just to start with a little bit of a sense of who our respondents were. So if you look, we have our provinces and territories in one column, followed by the percent of total respondents from each of those provinces and territories. And then we wanted to compare this to the percentage of the Canadian population. So if you look across those two percentage columns, we did pretty well in terms of representing, the patient partners in relation to the provincial share of the Canadian population, with a couple of exceptions. So Quebec and Alberta are highlighted here because these are two provinces where we were under kind of representing. So we had 12% of our total percentage of our total respondents came from Quebec when Quebec is 22, a little bit more than 22% of the Canadian population, and similarly 8% for Alberta, when it is actually representing 11.5% of the Canadian population. But I think otherwise, we felt pretty good about this. I think also important to highlight that some of you may be thinking of other ways of capturing geographic representation. And so of highly urbanized respondent groups, so 89% coming from urban areas. This is collected through postal code data. And so we're going to now just cover off three broad thematic areas. So we can't possibly share all of the very rich results from this data set with you today. So we're focusing on three key messages and showing some data slides related to each of these three key messages. So the first one is this really important, in answer to our question, who are Canada's patient partners? So in terms of who we surveyed, the patient partners who responded to our survey, we're quite a homogeneous group sociodemographically. So in terms of race, gender, age, employment status, socioeconomic status. So, perhaps not a surprise, since anecdotally many people talk about that homogeneous patient partner community. And again, emphasizing in terms of who we surveyed or who completed our surveys. I think a couple of things on this certainly reflects some segments, right? Some very important segments of the patient caregiver population, but it certainly underrepresents others, right? So we're very aware of that. Importantly, I think it reflects the barriers to achieving diversity within patient partner communities. And I think if you think about the timing of this, October, fall 2020, we have now had enormous shifts in thinking. And again, not that these were not ongoing equity issues that have been around for a very long time, but have been given much more significant prominence and attention since our survey was administered. And so thinking about the barriers to achieving diversity, something that I think many people in this space are actually working very hard on, but frankly quite challenged by. And I think for all kinds of really important reasons, that systemic underrepresentation of equity deserving populations in health policy more broadly. So not perhaps a surprise to see it also evident in the patient partner space. And so I think all this to say is that we need to do more work in this space and think about this in a very, very creative, very not so superficial way, that this is just a recruitment problem and we just need to diversify our patient partners. That's incredibly hard to do. And we need to think about how we explore different models of collaboration to support the achievement of diversity in patient partnership. And so just to show a few numbers, so combination of words and numbers here, this is our survey sample, right? If we look at women, we look at representation in terms of race, average age, university level of education and income, and then the prominence of chronic illness and self-reported health status as well. So it gives you a bit of a sense of who our respondents were. Now, taking a completely different tack on this, we would very much say that our survey findings show that patient partners are in fact a highly heterogeneous group. So homogeneous maybe in some ways, but highly heterogeneous in many other ways. And that is in terms of their kind of functioning and roles as patient partners. So over half of our respondents actually talked about partnering somewhat episodically with maybe just a couple of organizations, one or two organizations, and maybe not, fairly intensively, maybe a few hours per month. Some are doing a lot with a small number of organizations, so have that sense of kind of organizational loyalty, or I want to work with just one or two organizations. That's where I'm going to dedicate my efforts in this role. And then a small group of what we would describe as highly intensively engaged patient partners who are spending more than 40 hours per month working with multiple organizations on many different types of things in many different types of activities and roles. And so I think that speaks to this really important finding about varied aims and role trajectories and the need to carefully examine the challenges and supports needed for these different types of roles. So a very, very interesting finding, and I think quite novel, not anything that, you know, has really been captured before in any previous work. And so just to show, again, quantitatively, the number of hours per month spent on partnering activities. So high, you know, percentage spending 10 hours or less, another grouping in the 11 to 40 hours per month category, and then that really a small intensively engaged group. And so with respect to kind of, you know, their way, patient partners' way into their roles, you know, it's certainly fair to say that our findings show that patient partners work with a wide range of organizations, but when they first come into the role, and we ask that question, well, how did you first come into your role? Most commonly, they came in through hospitals, perhaps not surprisingly, with the very kind of common PPEC role that is out there, patient family advisory committees or councils, also with provincial health agencies and governments. But then I think, you know, as our results show, people have moved on into many, many, many different types of roles and with different types of organizations. And so our third key kind of theme here that we want to focus on, and this will really take up the rest of the formal part of the presentation, is this theme around the dynamics, the tensions in the patient partner community. And again, this is kind of honing in on those analytic domains around the philosophy, you know, the professional, the ethical piece, right, that we brought to our study. And so, you know, not a surprise that there were many different motivations and entry points into the role. You know, certainly important knowledge and skill gaps identified for many of our patient partners who responded to the survey. 2/3 faced barriers, you know, reported that they faced barriers in their role. Half reported being inadequately compensated. Between 1/3 and 1/2 had considered quitting. Sense of perceived positive value and influence for many. So, you know, a whole lot of things going on in this slide, right? This is one slide, but in fact, each one of these points could be unpacked in much more detail, and is to some extent in some of our subsequent, you know, the following slides, and also more comprehensively discussed in the paper. But I think it shows that there is a lot going on here, both, you know, challenges, some supports identified that could be helping to support the role, but also a really strong sense of positive value being made and influence through their roles. And so we'll want to just pick up on a few of these things with some of our subsequent slides. So when we asked about the question of your initial focus or motivation for coming into this role, the most common responses were, you know, I want to come into a role, I want to do something to improve the health system because I've had a negative experience. So over 1/3, you know, indicating that as their initial focus or motivation. And then, you know, a little bit less than that, talking about the giving back because it's of a positive experience, right? Or third common response being learning how the health system works. I want to improve my own care or the care of a family member. So looking to use their role to actually help them in their own patient partner role or as a caregiver. And then importantly, I think, you know, 10% of our respondents talked about the important role in serving their community. So really interesting mix here. And then in terms of skills and knowledge that patient partner respondents indicated they like to develop. So interesting, you know, knowledge specific to the area they're contributing. So the fact that 1/2 indicated this suggests to me that there's a lot more we can be doing to make sure that people know how that content knowledge related to, you know, whatever the engagement role or partnering activity is that they're contributing to, and equally that knowledge of the healthcare system, as well as the organization they're working with. I think sometimes patient partners come into roles and are sort of parachuted into something that's already got a whole lot of things going on without proper orientation to the organization itself that they're working with. And then on the skills side, about 1/3 talking about wanting to develop their research skills more fully, or their facilitation skills because they're being asked maybe to carry out these types of roles in their in their work. And so when we get to questions about barriers, and we gave them a long list, and then they also had an opportunity to add their own barriers. We had an interesting, certainly a wide array of comments about this. And again, we used a scale, and then they certainly could comment on this additionally. But in terms of the strong agreement or agreement with the items that we provided with them, certainly a very, a good number, over half, in fact, identifying power imbalances as a barrier. The use of acronyms and labels, unclear expectations, not feeling heard or feeling dismissed, and issues around scheduling and logistics. And, again, for many of you who either are patient partners yourselves or working in the engagement space to support this role, this may not be surprising, but I think it's important that, remembering this is 600 patient partners across Canada in many, many different roles. And it's not been captured in this way, in this kind of quantitative way, in this kind of really very, very specifically defined way. So we know the anecdotes, they're all, lots of them out there, but I think to capture it this way is really an important contribution to the field. And so now, and again, I've mentioned often already how the rich comments we have, and this just gives you a sense of this. When we ask the question about what's the most stressful part of your role or being a patient partner, we had some, really pretty important comments being made in this section. So over 500 comments. If you think about 600 respondents, that's almost everybody saying something in this category. And so I'll just let you glance at these on your own for a moment. So when we asked about perceived impacts, or how do you feel you've made a difference, had some influence in your role, really a wide range of comments here, ranging from, and I guess is in order of frequency. So, 3/4 talking about their sense of creating new knowledge or affecting the thinking of people in positions of influence, paving the way for others. Also feeling a sense of improving communication between patients, caregivers, and health systems, or improving the health system, in fact, itself for future patients and caregivers. A sense of, I really feel like I've affected decisions in healthcare. For some people, that's like the holy grail. This is what we're really after, right? I came into this because I wanted to make a difference. I wanted to actually shape decisions. And in fact, over half felt that they had done that. And others felt some uncertainty around this, right? A quarter of our respondents were not sure that they'd had influence. And some actually stated definitively that they did not have any influence. So I'm going to stop there in terms of sharing the findings from the survey itself, and maybe move on to the next portion. And this is where we can get into some discussion. And I see we're just after 1, so we've got a good amount of time for this. We have published 2 other papers from the study that you may find interesting to look at. One, this actually predated the survey paper that we've just been talking about. So this was a key learnings and recommendations paper that focused specifically on patient partnership based on the COVID experiences, because we asked a question about COVID. How has it affected, or has it affected your patient partnering roles? And if so, how? We wrote an entire paper just on COVID-related experiences. And I think, some of you may find that useful to look at, to think about how we are thinking about new ways of partnering because of the foundational impacts, right, that COVID has had on the way that we do our partnering work. And then the other paper is out of our review. Remember, that first phase of the work was a literature review. So we've actually published a systematic review of how we conceptualize patients as partners. And so this crosses research, health systems, education sectors, and I think offers some important insights into how we've conceptualized that role. And We are now working on several other papers. One is under review, the one focused on the role of expertise in patient partnering. So we have a question in the survey that asks, do you think the lived experience you bring to your role makes you an expert? Please explain. So a really fascinating analysis of this whole idea of experience and expertise in patient partnering. We are working on a paper looking at the experiences and attitudes towards compensation, being led by one of our doctoral students, and focusing on how the different types of compensation that people were offered and how frequently they were offered, their attitudes towards the compensation, and even reasons for refusing. That's actually going to be presented at the Canadian Association for Health Services and Research Policy annual policy conference in May, at the end of May in Montreal, if any of you are going to be attending that conference. And then the expertise paper is going to be presented at that same conference as well. And then a third paper that I'm working on now, which is quite fascinating, on thoughts about quitting. As I mentioned, we had 40% of our respondents indicated that they had given serious thought to quitting, and we had over 200 comments on this. So we're actually, working with that data now to analyze that. And so I think I'm going to pause there and have Carolyn weigh in on other aspects of the survey itself or any other aspect of the study before we move into our Q&A and discussion.
Thank you, Julia. I think our audience can recognize how much really interesting information was revealed and documented that, as she said, was available. Some of it was available by anecdote, but other aspects are entirely new. And, the anecdote of I feel like quitting, and to see that 40% of the population that we surveyed said yes, they had, it really suggests that there are all kinds of ways to better support and patient partners in their work. And it may be as simple as addressing the widespread feeling about not knowing if you've contributed anything. I mean, how easy is it to build into a patient partnership engagement a feedback loop and a very explicit way of recognizing the contribution of patient partners in a project or in an activity. So as I reflect on some of the revelations and the ways I've changed my thinking about patient partnership, is thinking about the extent to which the survey revealed some of the stereotypes or some of the identities that we kind of thought were there, the homogeneity, for example. So I reflect a lot on whether we asked ourselves the question and didn't look far enough at the variety of partnership and engagement patterns that are out there. Now, for example, there are lots of communities defined geographically by locale, or communities with common interests or with common health conditions who in fact do participate within our definition of what a patient partner is, but they're not in the sort of normal networks, the routine networks that we have for recruiting patient partners or for seeing each other. So it's like a parallel universe. And an example of that is the longstanding collaboration in the HIV community, that these are strong relationships that have existed over decades. And we may not have seen them in the same language with the same light as the patient partnership movement that has arisen over the last decade in particular. I was really interested in this distribution, which was a surprise for me, of people who have had a very few number, a large proportion of our sample had a very few number of organizations that they partnered with. And many of them had been only over a short period of time. So when I think of those multiple, the patient partners who have been involved in this work over a long period of time and have had many partners, what arose in my mind, perhaps, is that there are really two different kinds of partnership that we did capture. And one is the reflection of loyalty. A patient partner who has contributed to someone within the healthcare system, organization, or a particular study, or a kind of a way of tapping their experience and their knowledge, their insights, and has stuck with that. And it may be in the form of an advisory committee, a standing committee that participates a few times a year, but over a long period of time. The question we asked about intensity had to do with hours. And so if you look at that, it would be a few number of hours, but it might occur over 7, 8, 9 years. So that is really a kind of role of partnership. And that contrasts with another kind of patient partner that many of us are aware of, who are participating project by project, task by task, episodic involvement. And I look at the BC Patient Voices Network as a real exemplar of that, recruiting a large number of people distributed around the province, increasingly diverse, but who are attached to projects for very short to moderate length time, but it is task oriented. And in this way, those patient partners have an opportunity to see the health system from a lot of different perspectives. I also reflect on the motivations that may be positive or negative from experiences in healthcare. And I think it can be mixed. I mean, people, my own situation is very much that way, that it was initiated by a negative experience, but my impulse was full of the need to support the health system in better understanding the perspective of the clients of the healthcare system. So in that sense, it's positive. It's about reinforcing the good working of the system and my recognition of the quality of the people in healthcare who need this extra support, who need this extra point of view. So that's that kind of motivation helps define what is satisfying. And I think there are a lot of nuances buried in the questions we asked about what you think you achieved. But it certainly is interesting that so many people, 26% felt that they had, that they were unsure of what influence they might have had. I think if you ask people who are professionals in the healthcare system, if they've had any influence, they too would be stymied from time to time on whether they were to affect this large, complex, adaptive system that we know as healthcare, and what kind of results they could see, what kind of influence they could see.
Thanks, Carolyn. That's great. I noticed you were getting some thumbs up on some of your comments, and certainly that last point about the influence. Yeah, I certainly, over the course of my career, felt like absolutely no influence, but sometimes making some difference as well. So, well put. Okay, so we're going to open up for discussion and questions, and I know there are a few things that are coming into the chat, but there's also a Q&A section as well. One of the things we also wanted to put to you, if there aren't a lot of questions coming from you or things you want to discuss, is we're thinking about this unique opportunity that, remember, the title of this presentation, a snapshot in time, right? This was one survey at one point in time, at a particular point in time, that in some ways, I think gives us an interesting baseline or benchmark, because I think some people would say much has changed, right, since October 2020, in when we went into the field, and even when we submitted our proposal and started our work in 2019. And so we are thinking, we have had people say, boy, it might be quite different if you were to survey the same group now, or just take a survey into the patient partner world now, because the world has changed so much. So we're actually curious about that. And, one of the things that we wanted to put to you, and maybe if Laura might be able to put that question into the chat itself, is, as we're even analyzing our results and also thinking about the future, our future work in this space, who might we have been missing, right? In the way that we defined our patient partners, or said for patient partners to self-identify, this idea of, contributing to the health system to improvement in some way. Are we missing some key kind of constituencies of patient partners and advisors that we might want to reach out to, more effectively through our work? Also, as you saw, our team, right? And, it reflects to some extent who we are as a group, and, recognizing in some ways not a particularly diverse team in some regards. So who are we missing? Who, and what do we need to think? How do we need to think about that as we analyze our data, and maybe as we think about possibly a future survey in this space? And also, you know, how might we approach it? What are the trends in patient partnership, right, that we should think about capturing or trying to understand better, unpack, right, if we're continuing to do work this area? And even as we wrap up this work, even as we are now in our interview phase, right, interviewing patient partners to delve more deeply into some of these issues, what else should we be thinking about? We're interested in your thoughts. We assume because you've joined this webinar, you are experienced in your own way, in your own organizations or in your roles, and probably have some really useful insights to offer us as we think about our work going forward.
I'd like to respond to one of the questions that really seems most pertinent to me is what are the groups of patient partners that we may be missing because of the way we have a mental model about who is a patient partner and what does engagement look like. I think that many of the partners that we identified are people who are engaging one-on-one. It takes an individual resolve and that sense of agency to be able to approach the healthcare community, and the sense of confidence of entering that highly structured and often very hierarchical structure within healthcare as an outsider. So what are the attributes that we assume might be more broadly shared that in fact belongs to privileged, highly educated people with time on their hands, you know, all these characteristics that we were able to identify in this survey. So an example is there are certainly opportunities for rural communities to be highly engaged as a community in shaping healthcare services. I see that in British Columbia as a real emphasis in our healthcare system. This is from service design to research to evaluation, identifying needs, developing interprofessional healthcare teams and supporting them and so on. And you know, if you're a member of a community that's participating in a process like that, you absolutely fit into the definition, but you might not think of yourself in the terms of a patient partner if you saw a tweet advertising this survey, for example. So that's the kind of lens I'm thinking, what are the other ways in which the public, the patient, the caregiver community, the client community across our country actually engages and participates, that user perspective in any aspect of healthcare, in governance, in independent processes that articulate priorities. So I think that there are a lot of missed opportunities that we want to be tuned to. Mm-hmm. And to reflect what Julia just said, I really view this survey as a kind of baseline. It identifies and describes a pioneer era in patient partnership in Canada. Things have changed so much even since COVID, since 2020. There has been much greater consciousness, as Julia said, about populations that have not had their points of view understood or articulated and have not had that empowerment to be able to affect the system. And we also see different modalities of engagement. For example, going to where people are rather than asking the recipients of care to come into the healthcare institutions, instead going to where people live and work and suffer and self-care. Mm-hmm. I see we've got a couple of questions.
I'm going to go to Terry, who's got his hand up, and then I know there's some questions in the Q&A. One of which is you'll be repeating the survey, and I think we'd like to repeat it. And I think that's in a little bit in the spirit of the questions that we're asking you, right? If we were to do this, you know, what are your thoughts about how we would go about doing this? But Terry, I want to let you ask your question or provide your comment.
Yeah, it's in response to your question regarding, now I was a caregiver for 28 years for a rare disease patient, chronically ill, and I was advocating for her care for that whole time. But yet I was not a formal patient partner as it may be described. And And I know many chronically ill patients that know gaps in care, that are struggling to get their own care, but chronically ill patients don't have the time or the bandwidth or the spoons to actually really do anything except try to advocate for themselves. And that's a segment of the population that I don't know how we can engage them, support them, so that their perspectives are out there more, because there's so many people that it's just matter, every day is a struggle. They see the gaps in care, they experience the gaps in care, and yet their voice is not heard, their voice is missed because they don't have anything extra to try to do that. So how can we support those chronically ill patients to get their voice out there and give them some more supports? Thank you.
A really, really important comment. I appreciate it. And it is one of that, you know, those groups of patient partners. Yeah, they're absolutely out there, and they probably have a whole lot to say and probably really, you know, incredibly important things to share, but just the energy. And we did hear that from some people kind of as follow-ups to say, I started it, I didn't finish, I didn't have the, you know, the bandwidth, the time, the whatever, the energy. And they just, yeah, they absolutely couldn't do it. I think this also picks up on another question from Ron Redham about the survey dealing with lack of IT, right? Non-traditional patient partners, northern communities, old Mennonite areas, rural. So kind of picking up on a few other groups of people who certainly would have been eligible or, you know, kind of self-identifying, but because of the online aspect of the survey would not have been able to participate. So I think generating these kind of you know, sort of lists of, you know, these communities, these other patient partner groups to think about in many ways, you know, we didn't reach those who, you know, were really, really absolutely essential to reach. So if we were to do this again, we absolutely would have want to do it in a way that tried to reach out more comprehensively and in more inclusive, equitable ways.
Yeah, I'd like to just add something to what you've said, Julia, to Terry's question. So you're right, Terry. One of the sort of invisible barriers, it should be obvious now, and becoming obvious to many different engagement professionals, is that having time on your hands as well as technology is a prerequisite. Now, I've one avenue into the kind of inclusion that you suggest in your commentary is that I can see is that, for example, at the University of British Columbia, there's a health mentors program. I know that exists in other medical schools across the country or health professional education institutions. It's very often they're interprofessional. There are people who are self-managing chronic conditions. There are people who have in the past been caregivers to people with serious chronic conditions who have come in to share that lived experience with learners in the academic or professional training environment. Now, they can reflect their lack of resources at the time, the most intense time of providing that support, of providing that self-care when it was impossible to engage and to donate their contributions in that moment. So that opens the question for the health system, for actors across the health system. How can we reach out to access the points of view and concerns and opportunities to learn from the people who are most burdened? If we engage with patient partners who do not have the experience of those with the greatest burden of illness and burden of treatment, we're missing a huge portion of where our healthcare dollars go, where the support is, and where the value of the healthcare system is in society.
So I'm going to go to a question from Allison Koyman. Curious, if you don't mind me reading it, curious to understand about learning from the experience of groups, patient groups versus individual patient partners, which I think is a super interesting question. Thinking in terms of balance of power, how organizations respond to coordinated efforts by groups of patients versus, you know, one or two patient partners. So I think that the quick answer is we don't really. I mean, this is a survey. Individuals, you know, completed the survey as individuals. Maybe they were members of different groups. They certainly weren't bringing their own, you know, individual perspectives. I'm not we asked questions about, do you identify as an advocate, this, we have that, but I don't really think we've addressed the question. I think the way that you're asking about it, Allison, but I think it's a fantastic one. And this whole kind of straddling of advocacy, activist, partner, like there's a lot of really interesting, I think, reflection to do in that space. And certainly even kind of during and post-COVID, or not post, but during, as we continue to move through the different phases, seeing people saying, I'm tired of being in this role. I want to do something to really make it, I think advocacy or activism is the way to go. And they've kind of maybe turned their backs maybe on those traditional patient partner roles. Again, I'm simplifying this a bit. I think there's a lot of complexity and nuance to this, but some really interesting things going on.
May I, Julia, just add a bit to that?
Yeah.
So I think that one of the ways of looking at the results from our survey is to look at the invisible barriers that are embedded in the responses and the questions that we asked in the responses, particularly in the open text responses. Increasingly now, with a sensitivity about social accountability in healthcare, more organizations, more functional aspects of the healthcare system are reaching out to groups. Now, there are a lot of reasons for this, and part of it is that agency, but also it's where are the networks of trust? In order to participate in the healthcare system with agency, with a voice, with confidence that what you say is going to be heard, you really have to have that presumptive trust. And hopefully develop it in the course of an engagement opportunity. So if the healthcare system wants to engage with populations who don't have that prerequisite, reaching out into community networks, community groups, pre-existing structures that involve those people, those populations that are most of interest, and building on the existing relationships of trust is one way of surmounting the barrier to get beyond the most privileged population that we see participating just anecdotally, but now with some documentation with the healthcare system. Some of the techniques have to be totally different, really transformed. Go to where people are. And I think we're seeing this right now across the country with a lot of different population segments. I also think looking at different functional areas of the healthcare system begin to reveal methods of collaboration that have not been typical in the research world, or at least in the healthcare services and policy research world, and are not typical of healthcare provider engagement opportunities. And that has dominated in the last 10 to 15 years. I think we're going to see a real transformation. The whole idea of co-developing and co-designing, co-producing healthcare, I think, is really driving some of that curiosity and that broadening.
Patrick, I'm going to go to you to make a comment or ask a question.
Sure, thank you. And thanks for the great presentation. I particularly, I find it's going to be some of the results from this will be very useful in helping us recruit patient partners, and finding out who are our patient partners will help us better identify who we're missing, as well as how do we better engage with them. And it's in that spirit that I kind of have this question. You may be able to answer some of this from your surveys, but if not, it might be a good follow-up would be how many official language minorities filled out your survey? So I'm talking Francophones outside of Quebec, Anglophones in Quebec. Myself, I do a lot of work with official language minorities in Ontario, and we're finding it very challenging to recruit. We find it's the same people that come time and time again, so we're not getting that broad representation of the population or of that segment of the population. And it's challenging to do some of the things that you suggested, like going where they are, because they are such a hidden minority, and they're so distributed across the province, across the country, that it's hard to pinpoint, well, where are these groups from? So I was wondering if you had any information on that, if you had any data on them that would help us better identify who are these people and how can we better reach them?
Great question. So, and I'm going to say right off the top, and I know we've only got a couple of minutes left in the formal part, so people may be leaving, but it may be something to follow up with you about directly, Patrick, because I can't answer like in a perfect in the way that I want to, because I don't have those numbers on the top of my head. But as you know, we actually had a French language version of the survey, and I see Audrey L'Espérance in the webinar, which is great, and who was involved in helping us with that. And actually, you know, the French survey was predominantly, you know, completed by people in Quebec, not exclusively, but certainly very much so. But as you saw in that respondent slide, we didn't do as well as we would have liked in Quebec and with French language patient partners. So I think your comment, though, about it's easy to say go to where people are, it's not so easy to do. I've been, you know, thinking about this for quite a long time, and the whole participatory research field, I mean, this long predated patient partnership, health systems, you know, patient engagement, health systems. It's been a long, you know, journey in this space. And so I think we need to respect the fact that yes, we're kind of figuring this out now, late to the game in some respects. I'm being a little bit critical of my own kind of health sciences colleagues and community. But, you know, we are going to have to do better, right, in this space. And so I think the first step is, you know, understanding where the gaps are, and we're doing well at that. And then maybe taking some lessons and some cues from people who actually have that expertise, who've been working in this way for a much longer time than we have. But I think I never like to not answer the question, but I think if you don't mind, Patrick, maybe we can follow up with that very specific answer to you, because you had, you know, a particular question about data, and I'd like to be able to respond to you about that. So I'm going to wrap up and just thank, first of all, Carolyn for joining me in this foray. I think it was fabulous to have you involved, and it has been all the way through, right from just even starting the project itself and the seeds of the idea many years ago. Thank you very much for your contributions, for your reflections, and also thank you to all of you who took an hour out of your day to join us for this seminar. And we will be following up with slides and the recording, and also to say we will actually be having another webinar in June. We're going to take a break in May because we've got a lot of things going on, conferences, that sort of thing. Coming back June 14th, same time, same day, 12:30, Wednesday, June 14th. To focus actually on equity-centered engagement. So a little bit of a kind of follow-up on some of the points that are coming up at this last part of the webinar. So look forward to those of you who can attend the next webinar, and we'll let you get on with your days. Thanks again, everyone.
Thanks very much.